All right, so here we are at lecture 15. This is the advanced ankle and foot dry needling through the Haynes method, the hybrid dry needling certification. I hope to get most of this done in a fairly rapid time. There is a lot of content to go through for the ankle and the foot, similar that we did with the wrist and the hand. Lots of ligaments, lots of other things. So let's dive right in. Let's see here, going the wrong direction. Sorry, I've got a new computer, and make sure that we do this correctly. There we go. Okay, so as you can see, there's a lot to go over here. Some of it we have already covered, so I'll just briefly touch on that before we get into the rest of the material. Here we'll look at the lower leg, the intralateral lower leg, superficial, and the deep posterior, which we did look at when we were examining the knee. Again, we'll touch base with that briefly, but then we'll look into the plantar intrinsics, superficial, middle, deep, and then finally the fourth layer of musculature there, as well as the dorsal extrinsics. Then we'll get into the tendons and ligaments. As you can see by the list, they're voluminous on what we can deal with there. And then we'll get into our regional, we'll get into our perineural protocols first, and then we'll get into our regional, our diagnosis specific protocols. Start off with a little supporting evidence. This from Albelushi, published in is 2020. I'm looking for the date here, August of last year, so a little over a year ago. The objective of this study was to compare the effectiveness of dry needling versus percutaneous needle electrolysis. So looking at the difference between just standard dry needling without any electrical application to that with having the E-stem added on top of it. Both groups had some stretching. One had regular dry needling, and the other had percutaneous needling with electrolysis, applying an electrical current to that. Then the conclusion, after you look through all of the data, the conclusion they came up with was that both PNE and DN were effective for PHP management, reducing the mean and the maximum pain since the first treatment session, with long-lasting effects for 52 weeks and significant differences between the groups in the case of the quality of life at 52 weeks in favor of the PNE or the percutaneous needle electrolysis group. So I've long advocated the use of electrical stim when not contraindicated for increasing the effect that we see with dry needling. There are some patients that's just not possible, or again, it's just contraindicated for whatever reason. But what we do want to see if we can do is apply that and, like I said, increase the magnitude of the effect of the response. That is a hip. We're not at the hip, we're down at the foot and ankle. But again, what we'll start with is taking a look at the 3D kinetic screen. I'm not going to play through the entire thing, but obviously as we get down to possibly even our trunk rotation, but really as we get down to our single leg stance, our sit to stand, and our heel toe walking, those could be indicative of something that we need to look at a little closer. So we will come down here and take a look there. All right, I'm going to back this up, maybe just to those pieces. So the single leg stance, the sit to stand, I didn't include it in there in the list. The forward and the rearward quarter lunges. Just looking for symmetry, left versus right, quantity of movement. And then lastly, we would look at both the heel walking and the toe walking there. Assuming we've done a good physical exam, ruled out any neurological limitations on both the plantar flexors and the dorsiflexors, that may then lead us to look at something different in the anatomy of the ankle and foot joint themselves. So let's jump back now. Okay. Okay, again, the lower leg, intralateral lower leg. Here we looked at tib anterior, extensor digitorum longus, hallucis longus, the peroneals, and then superficially the gastroc, the soleus, the plantaris, and then more deeply in the popliteus, the flexor digitorum longus, flexor hallucis longus, and tibialis posterior. Those deep posterior lower leg muscles having a bigger function on the what we deal with as far as plantar fasciitis. We'll look at that a little bit more in depth as we get to our regional diagnosis specific protocols. Again, I'm just going to touch on these briefly since we've already dealt with these in the lower leg. So again, tib anterior. And I think what I will do is let's, instead of going through all of this content, again, we've got a lot to get to, and it's definitely here. It's also in the app for you to review. If you're having difficulty with the content, as far as in clinic, if you're not using the app that's been developed with all of this information in there, feel free to reach out to me, but you can go to https dryneedling.appguyverapp.com. I'm almost positive that's the exact address. If you can't find it there, message me and I'll make sure that you get the right address for that app. But definitely critical in clinic instead of walking around with 500 pages of a manual. It's all there at your fingertips and a great resource there. So let's do this here. The peroneus tertius, the longest laterally on the fibula, and then the brevis more distally. So let's look at the intralateral lower leg briefly here in our complete anatomy. Again, my 3D anatomy being brought by permission of the Sevier company, 3D anatomy application. Feel free to use any one that you like. I personally like this one, but I've used many different ones. They all provide good content. But again, critical for review of a three-dimensional approach to treatment of an invasive inserting needle into the skin. Need to know what it is that we're doing. All right, so where was I? Let's see if I've got it here. I know I did. If I can't find it, I may just have to bring a screen up. Let me do this. Let me drop to 14. It's got to be here. Okay, so what we'll do is I'm just going to pull up a screen and we'll just discuss it. Move that out of the way. All right, let's kill that. Okay, so for the anterolateral lower extremity, let me zoom in. It's kind of backwards here. So here we have tib anterior. Controls are kind of backwards. Tib anterior just lateral to the patellar ligament. Zoom in a little bit. Extensor digitorum longus. We'll have further down, we'll have the extensor hallucis longus. And we come laterally. Here we have peroneus or fibularis longus. I'm going to zoom in a little bit here so that you can see. Back out. Peroneus brevis and then peroneus tertius, fibularis tertius. I'm going to take away our nervous so that we can see a little bit better. And I'm going to take away our pen. All right. So next we'll get to the superficial layer. Here we're looking at, bring that down, the medial and lateral heads of the gastroc. I'm going to hide those. We have plantaris. Again, it's there. We name it. We can needle it if necessary. It's rarely going to be clinically relevant. Let me zoom in just a little bit tighter here. We're going to pull out the Achilles or the calcaneal tendon to get to the soleus. Again, the soleus, a big, broad muscle with both a fibular and a tibial origin with its attachment down through the tendocalcaneus into the calcaneus itself. And we'll deal with that a little bit later. We'll get to the deeper layer. I'm going to get rid of this fascial plane on both medial and lateral. And so here we'll be looking at the flexor hallucis longus. We'll look at tib posterior. We will so see flexor digitorum longus. Let me get in real tight for tib posterior. Okay, so that's the lower leg muscles. Where we'll look in a minute. We're going to cross this the mortise joint of the foot to get into all the muscles down in the foot. So let's move back here, and again we're gonna skip a good bit of our material since we've already covered it. Location for anterior tib, just down a couple of finger breadths, and then lateral 2 to 3. And for extensor digitorum longus, we end up coming down 3 finger breadths distal to the insertion needle, AP angulation there. It's superficial, anywhere 15 to 25 millimeters, and we might contact the fibula as our backdrop, going A to P on that. I'm going to go the right direction in a bit. Extensor hallucis longus. Again, that can be easily palpated on the distal third of the lower leg. We can come up about 4 to 5 finger breadths from the apex of the lateral malleolus, and then 1 finger breadth lateral, and then we can needle lateral to medial onto the tibia. But again, you can have your patient extend the big toe, and you'll be able to palpate that in that area. Peroneus tertius. We're going to be 4 finger breadths superior to the lateral malleolus, anterior to lateral fibular border, and going to go lateral to medial here with no backdrops. We're going to just thread just anterior to the fibula to get into the fibers there of peroneus tertius. For peroneus longus, will be 4 finger breadths distal from the fibular head. And we're just going to bracket that. It's a big prominent muscle. If you'll have your patients dorsiflex, evert, that'll pop out there nicely. Needle into that big muscle there. And to the peroneus brevis, going to sit on the lower half, the lower third of the fibula. So 4 finger breadths superior from the apex of the medial malleolus. We're just going to go lateral to medial with the fibula as the backdrop. Getting into the superficial posterior lower leg, here we will look at gastroc. We've already talked about these, so let's get to the needling themselves. Here we're going to identify that V notch, if it's palpable, of the the gastroc. Alternatively, we can just locate the popliteal crease and then come down 4 finger breadths. We can needle the medial head or the lateral head. Angulation will be slightly away from midline to avoid that neurovascular bundle on both the medial or the lateral. For the soleus, here we're basically going to find that line of demarcation between the muscle of the gastroc and then the calcaneal tendon or the Achilles tendon, and then just a finger breadth or so distal to that line, we'll needle. We can go medial or lateral to that midline for our needle location there. That we can take. We can try to take it down to backdrop, but it's not necessary. So we move on then to plantaris. Again, we've taught you how to needle plantaris. Again, we've got the popliteal fossa here. We want to stay away from that, but we do know that if we use proper placement, we can needle that safely if we feel like that muscle is indicative of pathology by either palpation or patient complaint. It's 1 finger breadth lateral from the midline of the popliteal crease, the level of the superior pole of the patella. And here we're going to go medial to lateral. That way our needle ends up going away from that neurovascular bundle. And because it is so deep, we will have to land on a backdrop of the femur in order to effectively treat that muscle. Into the lower leg, the deep posterior, popliteus, flexor digitorum longus, flexor hallucis longus, and tib posterior. So for the popliteus, an oddly shaped muscle responsible for helping unlock that knee from extension. I have had quite a few patients exhibiting problems related to this. We can also see it could be confused with IT band problems because of its origin and its insertion here. Again, this is one of the few muscles where the origin is the tendinous piece and the insertion is more the muscular belly on the medial aspect of the tibia there. So we'll move down to the treatment pieces as well. As far as location for popliteus, we're going to be at the opposite level of the fibular neck. And I use that because that's the uniform landmark that we can use. So we go to the opposite side, identify the fibular head, and then drop down into the fibular neck. And then we're going to carry that across to the other side. We're going to be 1 thumb breadth away from midline. Again, we want to avoid this neurovascular bundle. So we use patient's thumb, move 1 thumb breadth away from midline. And at the fibular neck, that is our needle location. It's going to be posterior to anterior. And the tibia is our backdrop. For the flexor digitorum longus here, quite simply, we're going to compress the medial gastroc soleus there at the mid calf. We're going to needle posterior to anterior, slightly lateral to medial with the lateral aspect of the tibia as a backdrop. You do have to needle through the soleus before reaching flexor digitorum longus, so a little longer needle length may be required than the 30 millimeter to reach therapeutic depth in the event of a larger body mass. For the flexor hallucis longus, very similar. Here we're going to compress the lateral gastroc or the lateral gastroc soleus complex at the mid calf, and then we're going to needle from posterior to anterior. And here we're going to use the fibula as a backdrop. Again, 40 millimeters may be enough. We may need something a little bit more lengthy to get to the depth to be therapeutic with our application of our dry needling. And then finally, tibialis posterior, we have 2 approaches here, both a lateral approach or a posterior approach. From the lateral approach, we're going to come down 3 finger breadths from the fibular head. And we're going to insert the needle in advance with a slight posterior and lateral, a slight posterior lateral to anteromedial angulation of approximately 10 degrees. That way we know we go slide slightly posterior to that fibula, and there's no backdrop there. Alternatively, from a posterior approach, we're just going to compress the lateral gastroc belly. That's just going to be 3 finger breadths distal to the fibular head, and the needle angulation is posterior to anterior toward the fibula as the backdrop. Okay, now we'll get into the meat of the matter. So we'll look at our plantar intrinsics and our dorsal intrinsics. In our plantar intrinsics superficial layer, we'll look at abductor hallucis, the flexor digitorum brevis, and the abductor digity minimi. So again, good information here. I want to talk about it through our 3D anatomy piece. But while we're here, just getting a picture. Very commonly, these are our first line of treatment. A lot of our plantar fasciitis dealing with abductor hallucis is frequently a first line of treatment, but we'll cover that. When we get to the wrong direction again, the flexor digitorum brevis. If you have to needle into the plantar aspect of the foot, and occasionally we do, flexor digitorum brevis frequently a place that we need to go, as well as the abductor digiti minimi. So those three muscles create that superficial layer where we can see some of our issues. We'll get to the middle layer, our Quadratus Plantae. So it comes off the calcaneus as well, inserting into our tendon of our flexor digitorum longus. Then we have so there we are. Our lumbricals that sit further deeply as well. Interestingly, their origin is the medial borders of the long flexor tendons. So flexor digitorum longus plays quite a role in what happens on the plantar surface of the foot. As we get into our regional diagnosis protocols, you'll see that because of that, most times our go-to approach for plantar fasciitis is dealing with that deep posterior lower leg musculature first, because of its insertion here and involvement with the plantar surface of the foot. And our deep layer, here we have our flexor hallucis brevis, our flexor digiti minimi brevis, and then our adductor hallucis. So our flexor hallucis brevis origin is on the plantar aspect of the cuneiforms, the plantar calcaneo-cuboid ligament, and the long plantar ligament. And like I said, I'm going to go into these specifically in a 3D anatomy. So let me come down, flexor digiti minimi brevis, and then get further to adductor hallucis. So similar to the adductor pollicis, you see that it has two heads, providing two lines of pull in that muscle, through that muscle to the great appendage here in the toe, and the hand onto the thumb to get that adductor movement. And wrong direction again. And then finally, on the plantar aspect, we have our dorsal and our plantar interossei. We'll needle both of those from. Actually, we needle both of those from the plantar surface. I mean, the dorsal surface, because it's a little bit more tolerant than in the plantar surface. And finally, we get to the dorsal intrinsics, the extensor hallucis brevis, and the extensor digitorum brevis. Very superficial muscles, small in nature, but they do. We can needle these, and we frequently will find patients with tissue in this area that we commonly think is an ankle problem. But any alteration in gait, we can start to see changes, muscle tension, pain in these two muscles. We needle these as a single unit because it's just hard to break out these two separately. There's a threading approach that we can needle across that. It seems horribly uncomfortable, but it's actually not that bad. Patients actually tolerate that quite well. So let's get into our treatment. Actually, let me go first to our 3D anatomy here. And let's come back to our library. I should have. Let's come up here. Got the nerves. Come on. Actually, I may have to filter this. Come in and filter real quick. All right. And bear with me. I've got a lot of the nerves. Where did my stuff go? Okay, so we're just going to do it the old-fashioned way. Close the library here. Okay. So let's come to the plantar surface first. Get rid of some of the soft tissue. So first on the Abductor Hallucis, its origin on the medial process of the calcaneal tuberosity and the flexor retinaculum of the foot and the plantar aponeurosis. It inserts into the medial aspect of the base of the proximal phalanx of the great toe, and its action is abduction of the great toe at its metatarsophalangeal joint, and it's innervated by the medial plantar nerve. Okay, so I'm going to hide that. Then we'll look at our Flexor Digitorum brevis. And so that's going to be more on the medial or the middle aspect here of the calcaneus. It's that which is at the origin, the medial process of the calcaneal tuberosity and the plantar aponeurosis, which is what we've pulled off already. It inserts in the plantar aspects of the bodies of the middle phalanges of the foot of the second, third, fourth, and then the little toes. So we can see if I can hide these and then bring that back up. And so there you see. Of course, it shows a slip. Come on now. Bring that back out. Easy. Okay, so there we see its insertion into that middle phalange there. Okay, so let's hide that. Let's try to zoom back out without messing this all up again. And then we get to the abductor digiti minimi. Again, here we have an origin, the medial and the lateral process of the calcaneal tuberosity and the plantar aponeurosis, and inserts lateral aspect of the base of the proximal phalanx of the little toe. So this superficial layer we frequently see can be problematic. Again, my first line of defense in our treatment in plantar fasciitis is that posterior lower, deep posterior lower leg. But then we come, my second is going to be into this group right here, our superficial group. So we will, let's hide that. And then let's move into our Quadratus Plantae here. See if I can zoom in just a little. There we go. Its origin, medial and lateral aspects of the plantar surface of the calcaneus, and inserts into the tendon of the flexor digitorum longus. So we're going to see both Quadratus Plantae and then the lumbricals attach onto this big broad tendon. Its action, it assists in the flexion of the second, third, fourth, and the little toe. So it just pulls posteriorly on that tendon of flexor digitorum longus. We'll hide that and get again to our lumbricals. So here's just the second. We have 1, 2, 3, 4 lumbricals, all coming off the flexor digitorum longus tendon and inserted in the medial aspect of the extensor expansion of those same corresponding toes. So let's hide those. Okay, then we'll get to our a little bit deeper level here, Flexor Hallucis Brevis. So that is going to be deep to our Flexor Hallucis longus tendon, and that tendon is, if you have your patient down, you extend that big toe. That is going to be that big guitar string, if you will, that you feel on the plantar surface headed towards the big toe. But the brevis itself, get back to that. So its origin, plantar surfaces of the cuboid and the lateral cuneiform bones and the tendon of the tibialis posterior. So its insertion in the medial and lateral aspects of the base of the proximal phalanx of the great toe. So obviously we see that the body's putting a lot of effort into great power there in the big toe. We'll also see that momentarily here. Well, let's go ahead and hide that and look at, so here's the oblique head of Adductor Hallucis, and here's the transverse head. On the transverse head, the origin is the plantar ligaments of the metatarso phalangeal joints and the deep transverse metatarsal ligament, and it inserts into the lateral aspect of the base of the proximal phalanx of the great toe. It's actually adducting the great toe at its metatarsal phalangeal joint, innervated by the deep branch of the lateral plantar nerve. And so let's hide that and then look at the oblique head. Here, its origin, plantar aspects, bases of the second to fourth metatarsal bones, tendon of the fibularis longus muscle. So you can see it. Here's fibularis or peroneus longus as it's, so we see it going past the lateral malleolus right here as it travels and crosses underneath, and it will have the attachment or the origin there of the oblique head of Adductor Hallucis. Inserts into the lateral aspect of the base of the proximal phalanx of the great toe, and its action, again, adducting the great toe. Also, it's innervated deep branch of the lateral plantar nerve. So let's hide that, get that out of our way. We do also see here, we'll get to that. Well, we'll touch base on that when we get to our ligaments. Okay. So we also have flexor digiti minimi, with origin plantar aspect of the base of the fifth metatarsal bone, and inserts into the plantar aspect of the base of the proximal phalanx of the little toe. So just a small flexor there. Let's hide that. And then we'll get to our interossei. So we're just looking at three of the plantar interossei here. Their origin, medial aspect of the base and body of the fifth, in this case, the fifth metatarsal bone. Inserts in the medial aspect, the base of the proximal phalanx. Each of them are of their respective, the second and the first plantar, their respective toes. Hide those, and then we will come up on the dorsal side, the fourth dorsal interosseous muscle. And again, these are the four distal muscles that are remaining, the interossei there. Their origin, lateral aspects of the body of the metatarsal bone and the medial aspect of the body. So the lateral and the medial aspect of their respective toes here. Their insertion, lateral aspect of the base of the proximal phalanx, and their action is abducting the toe at its metatarsal phalangeal joint and simultaneously flexing that joint and extending the IP joints of the respective toes. All right, so let's hide the dorsal interossei, which lastly will bring us back to, let me move this, our extensor hallucis brevis and extensor digitorum brevis. So extensor digitorum, its origin, the dorsolateral aspect of the calcaneus, inferior extensor retinaculum of the foot, and the talocalcaneal interosseous ligament. So we can see that it inserts the extensor expansion in the second to fourth toes. So travels quite a bit of distance there. And its action is extending the second to the fourth toes, innervated by the deep fibular nerve. We move to the extensor Hallucis Brevis. Again, origin dorsolateral aspect of the calcaneus, with the inferior extensor retinaculum of the foot and the talocalcaneal interosseous ligament inserting into the dorsal aspect, the base of the proximal phalanx of the great toe. Whoop, wrong direction. Let's ease that back out. So their insertion a little bit more come on. Out a little bit. So basically the brevis is going to have a more proximal insertion than will the longus for each of these. Those will have our terminal attachment on the terminal phalange. Okay, so let's, don't know if we'll need to, but let's go ahead and hide those. Okay. Let me share. Let's come back here. Okay. So here we are for the Abductor Hallucis. Our needle approach here. We're going to palpate for the Abductor Hallucis. We're going to have our subject forcefully splay their 5 toes while palpating near the medial calcaneus. And we're going to identify the centralmost aspect of that muscle belly. Half of the people have a hard time splaying their toes, but even if they try, you should be able to feel that muscle on that medial aspect as they attempt to do that. We're going to palpate for the anterior posterior border of the distal medial malleolus, and we're going to locate that midpoint. So halfway between the anterior and the posterior border. And then we're going to, our needle insertion point will be along that palpable muscle belly in line with the malleolar midpoint. We're going to direct it toward the medial process of the calcaneal tuberosity, directed toward the anterior mid-surface of the calcaneus with a 30 to 45 degree angulation toward the backdrop. So we're going to locate the muscle belly right there midpoint, and our needle angulation, as you can see with the direction of this arrow, is going to be towards the calcaneus itself. We should be able to get that below a line of demarcation between the softer skin above that and more of the plantar skin below it. If not, we've got to find that that palpable belly and then needle through there. So that's all right. Let's come to we're on to number 15. All right. Let's see where we are here. All right. So here the medial aspect, and what we'll do, going to identify that posterior border of the medial malleolus. Here I'm going to go ahead and mark all the way around so that we can find that anterior border. As we do that, our treatment location is going to be midpoint between those 2 points. I'm going to pause here. So it's kind of hard to see here, but there's a line of demarcation from a darker skin color on the plantar surface, especially up around the forefoot and back here on the heel. As you have your subject splay that toe, you will feel Abductor Hallucis all the way down the length to about almost to the metatarsal row. We're going to needle it right in midline between anterior and posterior. We're going to have them splay. We're going to palpate for that. Then we can bracket, and then we're going to needle back toward the calcaneus. We want to land at the midpoint of the calcaneus in that plane. I'm going to be kind to my subject. I'm going to use just an indicator. I'm not going to actually needle it. So again, I've had them splay to identify that. And then at that midpoint, then I'm going to needle in that angle, in that direction, back towards the calcaneus. And that'll give us our dry needling for Abductor Hallucis. All right, let's go back. So for Flexor Digitorum Brevis, here our approach is we'll use the anterior aspect of the medial malleolus as a guide. We're going to follow that line to the mid portion of the dorsal aspect of the foot. So a lot of the plantar parts of dry needling, I try to avoid needling directly into the plantar surface simply because of patient comfort. Unfortunately, this is a difficult one to stay out of that plantar surface. So we're going to insert our needle at the middle of the foot, and the angle is going to be 30 degrees relative to the plane of the bottom of the foot. And it's going to be more cranially toward the midpoint of the base of the calcaneal tuberosity. And so this one, we're just going to get down and dirty on this and just get it in through there. The needle length is going to be 2 to 3 centimeters because it's a fairly superficial muscle right there. And so then number 16, let's come back. Again, we're going to locate our anterior border of the malleolus. We're going to come down. We're going to find that midpoint on the plantar surface of the foot. And it's about a 30-degree angle relative to the skin, angled towards the base of the calcaneus there. Again, 2 to 3 centimeter needle length there. I would try to avoid, just again, for patient comfort, to not needle that unless you absolutely feel like it's the source of their discomfort or their physiological abnormality. All right. So we'll come back. All right. So for the abductor digiti minimi, here, what we're going to do, using the anterior aspect of the lateral malleolus here as a guide, we'll follow that line to the lateral portion of the dorsal aspect of the foot. So we're going to follow right distal in line with that anterior aspect. We're going to palpate for the abductor digiti minimi by having them again forcefully splay their toes while palpating near the lateral calcaneus. And then we'll identify the centralmost aspect of the muscle belly. So we're going to take the exact same approach as we did for the Adductor Hallucis. We're going to insert the needle at the middle aspect of the muscle belly. And again, we're going to angle it about 30 degrees relative to the plane of the bottom of the foot, a little bit cranially toward the lateral aspect of the base of the calcaneal tuberosity. So almost all of this, all of the muscle here, abductor digiti minimi, flexor digitorum brevis, and then abductor hallucis, all have an attachment there on, as does quadratus plantae, and one of the ligaments, the long plantar ligament, have attachment on the calcaneal tuberosity. So all of our needle angulation on this posterior half of the plantar surface of the foot is angled towards that calcaneal tuberosity. Okay. So again, we're going to use our anterior aspect of the lateral malleolus. Just going to identify what we've got here. So we identify that anterior piece. We're going to kind of splay. We're going to bracket as they splay and identify that muscle belly. So once we identify that muscle belly, needle angulation about 30 degrees angled towards the calcaneal tuberosity as such. Okay, then for the Quadratus Plantae, here I take a little different approach. So the Quadratus Plantae can be, as you can tell, it is going to lie deep to the Flexor Digitorum Brevis. So as we're needling Flexor Digitorum Brevis, sorry, there's a fly on my screen here. We will actually needle through Quadratus Plantae if we're hitting backdrop on the calcaneal tuberosity. If we want to isolate Quadratus Plantae, then we'll take this approach. Here we'll identify the posterior border of the medial malleolus, and then the line of demarcation, which is a slight change in the skin between the malleolus and the plantar surface of the foot. Needle placement here will be in line with the posterior aspect of the malleolus. So here we are at the posterior edge, and we're going to go slightly cranial to that that line of demarcation. Here, we're going to be angled approximately 45 degrees medially toward the plantar aspect of the foot. And we're going to have our fingers on the plantar aspect to use as a backdrop to determine proper depth. Again, this is the approach if you want to isolate Quadratus Plantae and avoid needling into the plantar aspect of the foot. Theoretically, you could advance the needle a little bit further into Flexor Digitorum Brevis, but I take the other approach. That way we absolutely know that we're getting the depth for that muscle. So for Quadratus Plantae. All right, hang on, I went too far here. There we go. Right there, yes. Let me move this a wee bit. Okay, so here we are, posterior aspect of the medial malleolus. We're going to identify that line of demarcation. Again, it's a little bit hard to see, but here we are sitting with it right here. And we're going to take about a 45-degree angle. My fingers aren't there, but normally your fingers would be on this plantar surface to make sure that we don't let the needle advance through the skin, but we take that approach to isolate Quadratus Plantae. Again, if you wanted to needle both Flexor Digitorum Brevis and Quadratus Plantae at the same time, you would simply take that from the plantar aspect towards the calcaneal tuberosity. All right. Then onto the lumbricals. Here, again, patient's going to be in the prone position. We're going to palpate for the metatarsal heads of digits 2, 3, 4, and 5. The needle placement will be 3 finger breadths proximal from the metatarsal head, and it'll be slightly medial from midline to avoid the neurovascular bundle in a perpendicular plane to the skin surface. So we're going to identify those metatarsal heads. We're going to drop 3 finger breadths more proximal, and needle length is just 1.5 centimeters. The thinner the needle that you can use here, the better. Again, patient comfort would make that more tolerable in that area. So let's look at that here. So for the lumbricals, again, we're going to palpate for those metatarsal heads from toes 2, 3, 4, and 5. Once we identify that metatarsal row, we're going to come back more proximally about 3 of your patient's finger breadths, and in between or next to the metatarsals themselves, we want to needle to try to stay away from midline. Gets a little challenging there, but with a thinner needle, 1.5, 2 centimeters at most, we will be able to hit our lumbricals. For our Flexor Hallucis Brevis, here, patient's going to be in the prone position. Needle length will be probably 1.5 to 3 centimeters at absolute most. 1.5 to 2 will get it there. Our backdrop is going to be down to our first metatarsal. So we're going to palpate for our metatarsal head of our digit 1 of the great toe, and then we're going to move similar to the lumbricals. We're going to move more proximal, about 3 finger breadths from that metatarsal head and midline to avoid the neurovascular bundle in a perpendicular plane to the skin surface. So we're just going to drop straight down onto that first metatarsal. So that looks like this. Again, we're going to find that metatarsal head. Then we're going to come back 3 finger breadths, and we're going to land onto the midpoint of that metatarsal. Again, if you can avoid this softer plantar surface, absolutely do. 1.5, 2 centimeters probably at most. The thinner the needle, the better on that surface. Okay, then Flexor Digity Minimi Brevis. Similar approach. We're going to identify the metatarsal head of digit number 5. So needle length here is definitely going to be 1.5 centimeters. Doesn't need to be any deeper than that. Backdrop is going to be down in the 5th metatarsal. So identify the 5th metatarsal head. We're going to back up 3 finger breadths, maybe 2 to 3 finger breadths, depending on what you're feeling there. And that's of your patient. And then we're going to needle perpendicular to the skin surface down to that 5th metatarsal. So here, so again, finding that metatarsal head on that 5th digit, we're going to come down about 3 of your patient's finger breadth, and then from the plantar surface up to the dorsal surface onto the metatarsal head there, of the metatarsal of the 5th toe. For Adductor Hallucis, 2 heads here. As the diagram shows, what we're going to do, we're going to palpate for the metatarsal head of digit 2. So I'm using the metatarsal heads because that's a nice landmark for a bulk of the things that we do on the plantar surface. So identify metatarsal head of digit 2, and then our needle placement will be both 1 and then 3 finger breadths proximal from that metatarsal head. It'll be in a perpendicular plane to the skin surface. The double needle placement will allow needling of both oblique and the transverse head. So we catch both heads just by going 1 finger breadth and then 3 finger breadths from that 2nd metatarsal head. Okay. All right, so here we are, 2nd metatarsal head. We do some flexing and extending to isolate that. We're going to drop 1 finger breadth for the transverse head, and then we'll drop 2 more finger breadths, or a total of 3 finger breadths from the metatarsal head for the oblique head. And it takes both placements in order to reach all of the Adductor Hallucis. So on that, again, 2 centimeters at most, 1.5 centimeter needle, nice and thin, should get the job done and have a happier patient with that. So moving on to the dorsal interossei. For the dorsal interossei, what we're going to do here, patient will be supine, the knee is on a bolster. Procedure for both the dorsal and the plantar interossei here. We'll dry needle from the dorsum of the foot together, depending on the digit being needled. We're going to palpate again for the metatarsal head of digits 2, 3, 4, and 5. Needle placement is going to be 2 finger breadths proximal from the metatarsal head and slightly medial to avoid the neurovascular bundle. It's going to be in a perpendicular plane to the skin surface. And plantar interossei we have for digits 2 through 5. It says plantar interossei again. It's the dorsal interossei are present for digits 2 through 5, and then the plantar interossei are present for digits 3 through 5. So number 23. And so we're going to look at both at the same time here. So for dorsal plantar interossei, going to find from the dorsal surface metatarsal heads 2, 3, 4, and 5 for the dorsal, 3, 4, and 5 for the plantar. Going to come back 2 more finger breaths and needle away from midline of those toes to avoid the neurovascular bundle. Then those for plantar and dorsal interossei. Plantar will be a little bit deeper than the dorsal. Okay, and then plantar interossei there. A person could needle the plantar interossei if they felt that they were the offending musculature that wanted to target, and do them from the plantar aspect. Again, what we would do would find the metatarsal heads of digits 3, 4, and 5, And then on their medial side, we can needle from the plantar surface into that. It'd be about 1.5 to 2 centimeters at most for that. But for patient comfort, I'd recommend taking it from the dorsal surface. Okay. For extensor hallucis brevis, extensor hallucis brevis, extensor digitorum brevis. Typically, we will needle these both at the same time. So what we'll do is we'll palpate for the extensor hallucis longus tendon and digitorum brevis tendon at the level of the navicular, near the midpoint of the arch of the dorsum of the foot. We're going to be 1 finger breadth lateral to the extensor hallucis longus tendon, and we're going to needle across and tangential to the navicular and the cuboid. We're going to use our fingers as a backdrop near the tuberosity of the 5th metatarsal bone. So as the arrow indicates, extensor hallucis longus here, we're going to come just lateral to that and needle across this. As you needle across, we've got superficial muscles. We've got extensor digitorum tendons themselves that are very ropey in this area, but is a nice way we can get underneath those tendons and needle across towards the base of the 5th metatarsal for our where we're aiming. So I will do, let's play both here. So what we're going to do is isolate extensor hallucis longus and find that tendon. And there at the level of the navicular, we're going to needle across towards the base of the 5th toe, which is right by my thumb right here. On this next one, I think I show a little bit more there. Again, isolate extensor hallucis longus. One thing I will point out, you can tell we've got a lot of veins in this area. Definitely you want to try to avoid. So I actually end up moving my pointer just a little bit to make sure that I'm not needling directly into any of these veins. So resist that, find my location. And I'm moving a little bit further lateral, but you can tell this muscle bulk right here, this is our target. The muscles themselves have their origin right here underneath my first index finger, my knuckle right here. And then they extend and travel over here. So we're taking this approach. We're going to thread all the way across. With my needle placement, I actually should be back another centimeter or so. Navicular actually sits right about here. And so we would want to get our better chance of hitting a lot more surface area, threading across like that. This is a case where you almost have to bend the needle. And when in lab, we can demonstrate that a little bit so that you stay below the surface of the skin, but you're still getting extensor digitorum brevis, extensor hallucis brevis. And then there we are with extensor digitorum brevis, and we just played that. Okay, so that is basically the nuts and bolts of what we see with all of the intrinsic musculature there in the lower, in the foot and the ankle. So let's move on into our tendons and our ligaments, similar to the wrist and hand. There are a lot, not always or all of these clinically relevant, but we want to bring them into play and be able to treat them if we feel like they are giving us a problem that we need to deal with. So for the superior extensor retinaculum, extends between the tibia and the fibula. It's proximal to the ankle joint. It binds the tendons of the extensor digitorum brevis, extensor digitorum longus, hallucis longus, tibia anterior, peroneus tertius, as well as the anterior tib vessels and the deep fibular nerve. So they are just a nice retinaculum or ligament that holds all of those things in place and doesn't let them move anterior. For dry needling this, we're going to use position is going to be supine, bolsters underneath the knee. Needle length is going to be 1.5 to 2 centimeters at the very most. 1.5 would be more than enough to needle in that. Here we're going to palpate for the space between the tib anterior and extensor hallucis. As long as if you do your resistive testing, you can identify that space between those two. There are going to be 4 finger breadths proximal from the medial malleolus. And we're going to needle between the 2 tendons of tib anterior, extensor hallucis longus, just going to go anterior to posterior. We're going to end up on the tibia as a backdrop. So superior extensor retinaculum. Okay, we're gonna come up our finger breadths. We're gonna find that space between tib anterior, extensor hallucis, and our needle placement will be in between those down to the tibia as our backdrop. Next will be the inferior extensor retinaculum, and it's the Y-shaped band that lies anterior to the ankle joint, and its fibers with its fibers directed medially and extending from the lateral malleolus to the medial malleolus, similar to the superior. It binds the tendons of extensor hallucis longus, extensor digitorum longus, tibia anterior, as well as other vessels and nerves. Gives them just a binding or prevents them from moving anterior and gives them that force on their tendons as they travel further distally. To needle this, again, supine bolster is underneath the knee. 1.5 centimeters should be more than enough needle. Our backdrop here is either the tibia, the talus, or it can be none. We're going to palpate for the tendon extensor digitorum longus and the angle of the ankle along a connecting line between medial and the lateral malleolus. The needle angulation is just going to be AP with or without the backdrop. And so anywhere in that medial to lateral approach will do. If you look for the extensor digitorum longus, that's a nice place to go in to catch the midpoint of that retinaculum. So the inferior extensor retinaculum as such. So palpating, finding medial lateral malleolus, finding extensor digitorum. I might have them extend, hopefully. There we go. Find midpoint of extensor digitorum. You can feel the tendons as they are retracting right there. And needle location is just going to be perpendicular to the surface of the skin. Again, 1.5 centimeters is going to be more than ample to complete what we're looking for there. Okay, now onto the inferior fibular retinaculum. This being a broad, thick band of deep fascia, it's the lateral continuation of the stem of the inferior extensor retinaculum. So we just needled this, and right past where the perineals cross, the distal aspect, more calcaneal, is the inferior fibular retinaculum. And here it attaches the fibular trochlea and the inferior lateral aspect of the calcaneus. It holds the peroneus longus and brevis tendons as well as associated bursa in place along the lateral margin of the foot. So as far as treatment, we're going to palpate below the lateral malleolus. We're going to have our subject plantar flex and evert the foot to identify the distal margin of the perineal tendons. A needle placement will be 1 finger breadth further distal and posterior to that inferior margin. We're going to be lateral to medial angulation. Our calcaneus is going to be the backdrop. Again, 1.5 centimeters at most. This is going to be fairly superficial. Inferior fibular retinaculum. So we've already identified our posterior inferior border of the malleolus. Plantar flex, evert to identify the perineal tendons. And we're going to be 1 finger breadth distal and posterior into inferior fibular retinaculum. We move on to the talonavicular ligament. Again, it connects the dorsal neck of the talus to the dorsal surface of the navicular bone. Here, we're going to palpate between extensor digitorum longus and extensor hallucis longus. The tendons there at the anterior angle of the ankle for this talonavicular junction. Needle placement will be between those two tendons, slight medial angulation with a backdrop onto the talonavicular junction. Here we're going to be supine, 1.5 centimeters at most superficial. And so let's look at talonavicular ligament. So once again, at a connecting line between medial lateral malleolus, locate extensor digitorum longus, extensor hallucis longus, and needle placement will be perpendicular to the surface of the skin between those two ligaments down to that junction. Again, 1.5 centimeter needle is going to be very adequate for what we need there. For the anterior tibiofibular ligament, so it consists of fibers which runs obliquely between the anterior distal tibia to the fibula. So just a connecting ligament here. For dry needling, again, supine with a 1.5 centimeter needle will be a backdrop down to the tibia. We're going to palpate for the distal and the anterior border of the fibula. Needle location will be 1 finger breadth anterior and superior from the antero-inferior border of the fibula, lateral to medial angulation. Tibia is going to be our backdrop. Again, the anterior tibiofibular ligament. Going to find that border, 1 finger breadth superior and anterior. Again, superficial 1.5 centimeters is going to be adequate for our therapeutic depth. For our anterior talofibular ligament, the ATFL, here is the anterior tibiofibular. Here we're going to be a little bit more inferior. The ATFL, much more common in pathology of ankle sprains, trauma. That tends to be the one more involved, likely simply because of the size of the ligament and the location of the forces that we endure. Its attachment, lateral malleus of the fibula and the neck of the talus, and it is one of the 3 ligaments of the lateral collateral ligament of the ankle joint. So for dry needling here, and I do recommend this for our lateral ankle sprains. Again, supine bolsters underneath the knee, 1.5 centimeters should be very adequate here. Our backdrop will be down to the talus. We'll palpate for the distal and the anterior border of the fibula and its distal junction with the talus. Needle location would be 1 finger breadth anterior to the antero-inferior border of the fibula and a lateral to medial angulation. The talus will be our backdrop. So let's move here. Anterior talofibular ligament, ATFL. I did that wrong again. Let me kill that. Okay. So we're going to find this anterior border. We're going to move 1 more finger breadth anterior, and we're going to drop 1.5 centimeter needle down into ATFL. Talus is our backdrop. Okay, the superior fibular retinaculum. So here we had the inferior fibular retinaculum earlier, continuation of the inferior retinaculum. Here we have the superior fibular retinaculum. Broad transverse band attaches to the lateral malleolus of the fibula. That's the lateral part of the calcaneus. Holds the fibularis longus and brevis tendons in place, as well as associated bursa. So several things get involved here. Here, again, supine bolsters underneath the knee. 1.5 centimeters is more than adequate. Calcaneus is our backdrop. We'll palpate for the distal border of the fibula and its distal junction with the calcaneus. Here, the needle location, 1 finger breadth inferior to the inferior border of the fibula, proximal distal angulation, and the calcaneus is our backdrop. All right. Yeah, our superior fibular retinaculum. We're going to find that inferior most piece, and we're just going to drop one more finger breadth distal for that superior fibular retinaculum. We'll move to the calcaneofibular ligament. Here we'll look at the lateral, it's attachment, proximal attachment, lateral malleolus of the fibula, and distal attachment is on the calcaneus. It's part of the lateral collateral ligament of the ankle joint, and its action is lateral ankle stabilization. Our procedure here will palpate for the distal border of the fibula and its distal junction with the calcaneus. Needle location is going to be one finger breadth inferior to that proximal to distal angulation. Calcaneus is our backdrop, and it's the same protocol as the superior fibular retinaculum. So the superior fibular retinaculum sits more superficial to the calcaneofibular ligament. So you needle one, you're going to needle both. One is just more of a and odds are these are more contiguous than we would like to think, but we use that previous approach and we'll needle the same thing. So I'm not going to show that a second time. Finally, we'll get to the third piece of the lateral collateral ligament of the ankle. And it's the posterior talofibular ligament. Lateral malleolus as the proximal attachment, and then distally onto the talus itself. So it wraps around quite a bit here. Again, it's about lateral ankle stabilization. We'll be prone here. Needle length, again, it's going to be 1.5 centimeters. Backdrop is down to the talus. We're going to palpate for the posterior aspect of the distal fibula, and then one finger breadth posterior and a 45-degree posterolateral to anteromedial angulation with the talus as a backdrop. So this is number 35. We just did that. Okay. Again, finding that posterior aspect of the lateral malleolus, and we're going to move one finger breadth, and this is going to be at about a 45-degree to land on the talus as our backdrop for that third piece of that lateral ligament complex. Then we have a transverse tibiofibular ligament. Fibers of the tibiofibular ligament make up the deep component, posterior tibiofibular ligament. They make up a cone-shaped band of fibers that run from the proximal area of the malleolar fossa across the posterior aspect of the talus, insert into the posterior edge of the tibia and the medial malleolus. So just another piece of posterior support between the tibia and the fibula. Here we'll be prone again. Needle length 1.5 centimeters up to 2 centimeters. Our backdrop is down to the talus. We're going to palpate for the posterior aspect of the distal fibula. We're going to insert our needle one finger breadth further posterior, one finger breadth superior, 45-degree posterolateral to anteromedial angulation with the talus as our backdrop. So our big takeaway there is the one finger breadth posterior and then superior to isolate. Skip. You know, 1 second. I think I may have skipped one. Posterior talofibular. All right, let me jump back real quick. Okay, that is the transverse tibiofibular. Okay. Brain was off just a little bit. Well, I definitely don't need that. Bear with me. Better clear something here. Okay. Okay, transverse tibiofibular. So that 1 finger breadth posterior and then 1 finger breadth superior. Again, that posterolateral to anteromedial. This line of the talus is our backdrop. Again, part of the reason I recommend using the app, there are so many different specific finger breadths from all of the different structures, so much easier to have that at hand to be able to isolate what it is without trying to keep all of this just stored in your brain. Because I promise you, you'll never remember it all. Even I have to use the app or my reference to find all of the exact locations for so many of these. So, all right, now the posterior tibiofibular ligament. Let's just come here. So here again, we're going to be prone, needle length 1.5 up to 2 centimeters. Here, the tibia is going to be our backdrop. So we're going to palpate for the posterior aspect of the distal fibula, and then we're going to needle insertion point be 2 finger breadths posterior and then 2 finger breadths superior, and a posterior to anterior angulation slightly lateral to the Achilles tendon. And again, the tibia is our backdrop. So posterior border of the lateral malleolus, 2 finger breadths further posterior, 2 finger breadths superior, come 2 posterior, 2 superior, just lateral to the Achilles tendon, and then down to our backdrop. And that's posterior tibiofibular ligament. For the flexor retinaculum, it's a strong band of fiber, extends from the malleolus of the tibia to the calcaneus. Its action, it encloses the tendons of the flexor muscles as well as the posterior tibial vessels and the tibial nerve. For dry needling, again, here will be supine, foot bolsters underneath the knee. 1.5 up to 2 centimeters is going to be adequate. Our backdrop will be either to the talus or the calcaneus. We'll palpate for the distal posterior corner of the medial malleolus. Needle location is going to be 1 finger breadth distal from that location, medial to lateral, with the talus as the backdrop. So finding that posterior aspect of the medial malleolus, 1 finger breadth posterior, slightly inferior right there. Again, down to the talus or the calcaneus is our backdrop. And then we get to the deltoid ligament. So the deltoid is made up of 4 different ligaments here on the medial aspect. The first part, the posterior tibial part, let's come here. So for the posterior tibial part, we're going to palpate. So here position, we're going to be sideline. The treatment leg is mat side. So you want to position so that the sky side leg is out of the way. Needle length 1.5 up to 3 centimeters. Let's say it's 1.5 up to 2 centimeters, probably at most, depending on your body shape. Backdrop here is going to be the talus. We're going to palpate the anterior posterior margins of the distal tibia and the medial malleolus. We'll palpate the anterior inferior aspect of the medial malleolus to identify the process that extends further inferiorly. As you palpate further posteriorly, you can identify a groove between anterior and posterior aspects of the malleolus. So this space right in here. We're going to place our index finger at the posterior margin of the inferior-most aspect of the anterior-inferior process, and it will lie directly on top of the tibiocalcaneal ligament. To needle the posterior tibial ligament, we'll insert the needle the posterior border of your index finger in line with the distal margin of the malleolus. Medial to lateral, angulation with the talus as a backdrop. And so that's going to be posterior here. So I include this on each one of these slides. Basically, the deltoid ligament, we're going to do 3 in a row at the lateral aspect. Then we're going to come a little bit more anterior for the navicular piece. But let's get number 39. And 39 is deltoid, the posterior tibial ligament. Again, we're here supine. We're going to take a bit. We're going to palpate that space in between the inferiormost aspect, and we're going to go to the posterior aspect of the finger right there. Okay, we move on to the anterior tibio-talar part. So here, we're going to palpate for the anterior and the posterior margins, the distal tibia, medial malleolus, where we'll palpate the inferior aspect of the medial malleolus to identify the process extends further and inferiorly, similar to what we did previously. Here we're going to locate the tendon of the anterior tibialis at the angle of the lower leg and the foot at the ankle. Needle placement will be between anterior tib tendon and the anterior inferior malleolar process. This is going to be a 45-degree supromedial to infralateral angulation, and the talus will be our backdrop. So here, number 40. So here we're coming a little bit more anterior. Going to identify anterior tib, and then about a 45-degree down to the talus as our backdrop. Okay, now the tibiocalcaneal part. So similar, we're going to find this inferiormost process off of the medial malleolus. From that line, we're going to drop down 1 finger breadth from that location, almost in line with the tibia itself. And here the talus will be our backdrop. So again, we'll come in, we'll find that inferiormost aspect of that medial malleolus, and 1 finger breadth further distally will be our needle placement. And this is for the deltoid ligament, the tibiocalcaneal part, the deltoid ligament. All right. And then finally, the tibio-navicular part. So here, again, we're going to find that inferiormost aspect of the medial malleolus to identify that process. And you palpate further posteriorly, you can identify the groove. We're going to place our index finger at the posterior margin of the inferiormost aspect of the anterior inferior process, and it'll lie directly on top of the tibiocalcaneal ligament. To needle the tibio-navicular ligament, we're going to insert the needle to the anterior border of the index finger in line with the distal margin of the malleolus. Medial to lateral angulation, talus is our backdrop. And so basically we're just going to come, so we came 1 finger breadth distal from the medial aspect. We're going to move 1 finger breadth anterior. So like we said previously, you can basically take, if you identify this medialmost aspect, you're going to needle 1 finger breadth distally. You can needle 1 finger breadth posteriorly, 1 finger breadth anteriorly, as demonstrated there. Okay. Okay, we're going to locate that inferiormost process. Here we're going to be 1 finger breadth anterior to that. We'll move to the plantar calcaneonavicular ligament that connects the calcaneus to the navicular bone. Treatment here, sideline. Treatment foot is mat side. Needle length 2 to 3, 1.5 to 2.5. That's probably all the depth that you will need here. Backdrop is down to the calcaneus. We're going to palpate the anterior inferior border of the medial malleolus. So we're going to find this border right here. We're going to drop 2 finger breadths further distally, palpate the junction between the calcaneus and the navicular. And the needle placement will be 1 finger breadth further distal at the joint junction at 45 degrees from posteromedial to anterolateral with the calcaneus as a backdrop. So we'll drop 2 finger breadths from that junction, and then it's going to be 1 finger breadth further distal. So a total of 3 finger breadths. So we're coming down. We're going to drop 2 and then 1 additional further. So two distal towards the mat and then 1 distal down the ray, the first ray. And that gives us our plantar calcaneonavicular ligament. Our plantar aponeurosis and our medial calcaneal tuberosity. Rarely will we needle this individually because we're going to be needling Abductor Hallucis, Flexor Digitorum Brevis, and Abductor Digity Minimi, or the Quadratus Plantae further deep. But superficial to that will be the plantar aponeurosis, again, with that medial calcaneal tuberosity being a high prime target for what we want to needle there. So for this aponeurosis specifically, we'll identify the distal aspect of the cushion of the heel for our first insertion point. And needle length is going to be 3 centimeters. It's going to be angled cranially and posteriorly with the medial calcaneal tuberosity as our backdrop. To identify the second point, we're going to palpate the taut band at the midpoint between the first needle point and the metatarsal head of the first toe. And the needle length here is about 1.5 centimeters, and there is no backdrop. Okay, so we've found the anterior aspect or the distal aspect of the pad, and then the first metatarsal head. Midpoint will be our second location. At the base of the thumb is our first location right there. And again, that is for our plantar aponeurosis and then medial or mesial, medial calcaneal tuberosity. All right, I don't need that. Okay. And then the long plantar ligament is deep to our plantar aponeurosis, deep to Quadratus Plantae. Frequently, people would say that that's the culprit and what we need to treat for plantar fasciitis. I think it's more muscular, quite honestly, in the majority of cases. Anyway, it connects the calcaneus to the cuboid and the lateral metatarsals on the plantar surface of the foot. Its action, it provides a passive support system for maintaining the longitudinal arch. So for dry needling that, we're going to locate the distal aspect of the pad of the heel. Needle insertion will be in the lateral half of the foot, just distal to the pad. We'll go plantar to dorsal, and the calcaneus is our backdrop. So we find that distal part of the cushion, and we're going to angle a little bit more laterally. I could have been a little bit further lateral there, or I could just angle the needle a little bit laterally. But again, we're going to needle through a lot more muscle and the long plantar ligament itself as we're getting to that. So let's come back. We're almost through with the tendons and ligaments. medial talocalcaneal ligament. Here, we're going to palpate distal to the posterior aspect of the medial malleolus. And we're going to palpate for the talus. You should be able to identify the posterior and inferior border of the talus here, and it'll be tender around the tibial nerve. So you want to be cautious on your palpation there. We're going to palpate further distally toward the toes, and about 1 finger breadth to locate the sustentaculum tali. And it's easily palpable as we get there. The medial talocalcaneal ligament is needled 1 finger breadth posterior to the sustentaculum tali, and a medial to lateral angulation. The calcaneus is our backdrop. So, okay, well, posterior edge, we're going to drop down and locate that sustentaculum tali, and we're going to be 1 finger breadth posterior to that. Again, caution for that tibial nerve because it can be tender in that area. Split between and bracket. And that is for the medial talocalcaneal ligament. All right, and lastly, the Achilles tendon, both the musculotendinous and the tenoosseous junction. So when we get to the protocol for that, we like to make sure that we hit both of those. Something is the source of the tendonitis, whether it's an acute onset or whether it's something more subacute or chronic. You need to deal with that. But as far as the tendinous piece itself, we'll palpate for the junction of the Achilles tendon and the gastroc. Needle location at this location. Needle location will be at this junction in a posterior to anterior angulation with 2 needles on the away from midline, about 1 finger breadth medial and 1 finger breadth lateral. We're then going to come down and palpate for the attachment of the Achilles tendon to the calcaneus. Here, the needle location will be at this junction with the calcaneus as a backdrop, and using a 1.5 centimeter needle pecking onto the periosteum and a P to A angulation. And here. So for the calcaneus itself, well, we'll identify it. That's its inferior-most attachment there. We also want to know where the gastroc separates away from the tendon itself, because that's our musculotendinous junction. And so we'll drop inferior to that. We'll do 1 finger breadth lateral from midline and 1 finger breadth medial, or medial and lateral. For the tendon itself at its insertion, we're just going to needle through the meat of that tendon down to the calcaneus as our backdrop. All right. Now we'll move on to our perineural protocols. Here we'll look at tibial nerve, the lateral surocutaneous, medial surocutaneous, common perineal, deep perineal, superficial perineal, sural saphenous, and dorsal cutaneous. Some of these we've already covered when we talked about the knee. So we'll touch base on these as we go through them. For the tibial nerve, so it has muscular branches, some cutaneous branches, and then articular branches that give us part of what we look at for our genicular protocol. The cutaneous branches, and it's the medial sural nerve from the middle of the popliteal fossa. We are talking about perineural here, more probably for motor enhancement than for the sensory piece. We will come down and needle the cutaneous branches specifically in a moment, but right now I would want to target the tibial nerve more so, again, if we're having an innervation or a motor control problem with something that is being provided its muscular piece. tibial nerve comes from L4, L5, S1, 2, and 3. So for that, our primary locations are going to be the bifurcation of the distal hamstrings. So right in between the two, our needle length here is only going to be about a centimeter and a half up to 3 centimeters. So even though we're in midline, we're going to keep our needle shallow enough so that we stay away from that vascular bundle. We want to have an impact not directly on the tibial nerve, but in and near it. So we'll do it bifurcation of the distal hamstrings. We're going to do it at the midline in the midpoint of the gastroc, and that'll be our medial sural nerve, and then the midpoint between the medial malleolus and the calcaneus. So our secondary muscular locations here will have the gastroc, soleus, tib posterior, abductor hallucis, abductor digiti minimi, all muscles innervated by branches of the tibial nerve. And then we can also come up to its proximal spinal segmental locations, 4, 5, 1, S2, S3. So for our tibial nerve, let's see if I can make this work now. Very good. So again, we'll look at bifurcation of the distal hamstrings and the gastroc. We'll come dealing with the gastroc and soleus itself here. And then deeper, we'll also catch the deeper posterior muscle group, flexor digitorum longus, flexor hallucis longus, but then also we'll have a little bit of the sensory component here at the Achilles, just between the Achilles and the malleolus. So we'll move from there. Wrong direction again. For the lateral surocutaneous nerve, we covered this in our previous, our knee, but we will discuss that briefly. So here are our location, our neurolocations: posterior the biceps femoris, at the lateral femoral condyle, 4 finger breadths distal from the fibular head and the peroneus longus, and then the distal third of the peroneus longus, further distal down here. There are our proximal spinal segmental locations would be L5, S1, S2. We discussed this previously talking about the knee, so I'm going to leave that alone. We can go back and review that in the previous video. Then we'll have the medial sural cutaneous nerve. So here, I'm going to move from here down to our protocol. So here we will have primary location at the bifurcation of 2 heads of the proximal gastroc. Again, we're going to be 1.5, 2 centimeters. So not a whole lot of concern about the neurovascular bundle here. Just want to elicit that response there in the nerve itself. We'll also be at the musculotendinous junction of the Achilles in midline. And we'll also be at a midpoint between those two. If we want to look proximally at the spinal segmental locations, the medial surocutaneous nerve gets its innervation through branches of the L5, S1, and S2. Look at that here. So again, we'll be here, well, at the bifurcation of the proximal gastrocs here. Again, 1.5 to 2 centimeters. We'll be at the musculotendinous junction of the Achilles, gastroc Achilles in midline. And then we're just going to take a spot in between those two. That's for the um, cerulocutaneous. Oh, back there. Let's come back. Medial cerulocutaneous. Okay, the common perineal. So common perineal, common fibular nerve. It's a small terminal branch of the sciatic nerve. It gives way to other nerves, the lateral cerulocutaneous, the cerulocommunicating soup. And then we get three branches of the genicular nerve from that: the superior lateral genicular, inferior lateral genicular, and recurrent genicular, which we deal with those in our genicular protocol that we just talked about at the knee. But here we just want to have some impact on the common perineal, similar to tibial nerve earlier. Really, in this particular protocol, more interested in the impact we can have on those muscles that are innervated by the common perineal nerve. So here, to have our impact, we're going to, our primary neural location, the superior angle of the popliteal fossa. And we're going to be posterior to the biceps femoris at the lateral femoral condyle. Will be 1 finger breadth distal to the fibular neck and the peroneus longus, and then we'll throw in the pieces of the lateral cerulocutaneous nerve. These will be 1.5 to 3 centimeters, so staying superficial. From a secondary muscle location, we could hit the short head, the bicep femoris right there. And then from a proximal spinal segmental location, it would be L4 through S2. So common perineal. Up here we go. So bicep femoris, the short head, will come in posterior to the long head of the bicep femoris. We will then come and catch the lateral cerulocutaneous nerve innervation as well. We'll also catch the bicep, or midline between the heads of the hamstrings. All right. For the deep perineal nerve. So here will be supine. Okay, will be supine. Will be our primary neural location will be 1 finger breadth distal from the fibular neck and the peroneus longus, and then we'll be into the extensor hallucis longus. Secondary muscle locations would be tib anterior, extensor digitorum longus. So deep perineal. There we are. So deep perineal, what we'll look at, we're going to catch all of these: anterior tib, extensor digitorum longus, peroneus longus, and then we will drop into extensor hallucis longus. And that's for deep perineal. Bring that back a little bit. There we go. For the superficial perineal, it does have cutaneous branches supplying the skin over the lower 1/3 of the lateral side of the leg and the greater part of the dorsum of the foot, except for areas supplied by the saphenous nerve, which is the medial side of the leg, the sural nerve, and the deep perineal, which is the first web space of the dorsum of the foot. Let me go the correct direction. So for superficial, primary neural location, we're going to be 1 finger breadth distal to the fibular neck and the peroneus longus. So as you can tell, any of the fibular, common, deep, superficial, we're going to go after that nerve as it comes around, finger breadth distal to the fibular neck. But we'll be there. We'll also come down into peroneus tertius. From a muscular standpoint, we'll hit peroneus longus and brevis as well. And then proximal spinal segmental location would be at L4, L5, S1. wrong share. Let's come here. Superficial. There we are. So again, what we're really interested in is the perineal nerve, and you can see it coursing behind peroneus longus, anterior to or superficial to the fibula at approximately the fibular neck. So we'll drop 1 finger breadth there superficially. Then we'll drop down the 3 to 4 finger breadths to get into the peroneus longus proper. And then we will get into peroneus brevis and peroneus tertius. This is for superficial peroneal nerve. Then for the sural nerve, our primary location here, let me come back. So you can see the sural nerve providing innervation on the posterior lateral aspect of the lower leg. For this, let me go the right direction. Our primary neural location will be at the lateral musculotendinous junction of the Achilles tendon, right here. Then will be 1 finger breadth posterior to the lateral malleolus. And it doesn't say it here, but we're also going to take a spot midway between those two locations. So just lateral to the musculotendinous junction of the Achilles tendon, finger breadth posterior to lateral malleolus, and then a midpoint. Segmentally, we can do L4 all the way to S4. So for the sural nerve, back to our library. All right, so here you see just distal to that musculotendinous junction, and we're going to be a little lateral of that. We're going to be 1 finger breadth posterior to the lateral malleolus, and then we're going to just have 1 spot midway between those, probably just lateral to the Achilles tendon itself as that nerve courses through that direction. Then finally, the saphenous or the medial crural cutaneous nerve. And so this is the area that we get on the medial aspect for the saphenous and the medial crural nerve. So for this, our protocol will be at the medial knee joint line at the pes tendons. Will be at the mid-tibial shaft, and we're going to thread across that tibial shaft. Very superficial. Takes a little bit of some finesse to get superficial right there. And then to the anterior aspect of the medial malleolus. From a proximal spinal segmental standpoint, we would be L2, L3, L4 for the saphenous nerve. Here we are. So again, we'll be at, let's catch up. The medial joint line here at where the pes is crossing that medial joint line. We'll have 1 there. We will come at midpoint of the tibial shaft, and we're going to thread from lateral, from anterior lateral to posterior medial, just threading across that very superficial skin right there to get our response there. And then we'll come down further and we will be zooming, just anterior to the medial malleolus. There, again, saying superficial with that. Okay, the dorsal cutaneous nerve. So just a small section that provides sensation to the dorsum of the foot. Here, it is the terminal branch of the superficial fibular nerve. So it could have been needled with the superficial fibular nerve as well. But if we want to target this, we can do it at the inferior extensor retinaculum over here that we hit at the extensor digitorum. It could be then 2 finger breadths distal from the dorsal ankle crease in midline and at the base of the 4th metatarsal. And so we're going to hit just a small little triangle right here. Segmentally, we could hit L4 through S1. One more here. Where's my library? D. Again, so we're going to catch it here at this inferior extensor retinaculum. We'll come a little bit further into, so if we were having sensory issues in this area, and if we were to thread across extensor digitorum brevis, extensor hallucis brevis, we would get these other 2 spots right here. And that would be a nice alternative for that as well. So those 3 spots right there. Okay. Finally, we'll get into our regional or diagnosis specific protocols. Here we're going to look at our shin splints, foot drop, peroneal tendonitis, our lateral ankle sprain, Achilles tendonitis, Achilles and malleolar bursitis, plantar fasciitis, tenosynovitis, which I'll cover one. I'm not going to cover each and every one of these. We know what we're doing here, but we'll demonstrate on one. Then we'll look at peripheral neuropathy, and then finally we'll take a look at Haglund's deformity. So for shin splints, this reference is going to be here for you to review for time's sake. So we don't run out of time, I'm going to let you review that on your own. So for shin splints, our primary location is we want to go target anterior tib. Predominantly shin splints involve the anterior tib. Anecdotal, I've needled my wife's shin splints many years back, have not been a problem since. And she was a recurrent shin splint problem. So phenomenal improvement with that. But if we're there, primary location, hit extensor, hit anterior tib, and then come back and hit extensor digitorum longus. Our secondary, if that's not effective, let's hit peroneus longus and then extensor hallucis longus. Lastly, if we're not getting that, let's come up more proximally and let's hit biceps femoris tendon in the distal IT band. Just everything that's proximal to that distal joint line into that lateral compartment. So let's sneak over here. Here. Grab my library back. So for shin splints, most definitely we start our primary anterior tib, extensor digitorum longus. Still not seeing the improvement, we'll drop out to peroneus longus and extensor hallucis longus. And then if still not the results that we want to, let's consider it could be something a little bit different. The tendon of bicep femoris and the IT band as it's crossing over to Gertie's tubercle there. So shin splints, again, great treatment approach there. For foot drop, several things we want to consider here. Let's see here. Stay with me. Number one, the muscles of the foot drop. Tibia anterior, extensor digitorum longus, extensor hallucis longus. Those are the ones that we want to get our action out of those. Secondary, let's hit the perineals. Longus, brevis, tertius. Tertiary, third, extensor digitorum brevis, extensor hallucis brevis. I would say let's also add into this our tibial nerve, our common perineal nerve, to see if we can elicit a motor response as well. So not just hitting these individual muscles, but also the nerve piece as well. All right, I'm gonna computer catch up here. There we go. Okay, so again, forefoot drop from the muscle piece itself. We want to get these muscles firing, doing a better job. Anterior tib, extensor digitorum, and extensor hallucis longus. Secondary approach, let's hit the perineals, peroneus longus, brevis, and tertius. Lastly, it's hard to see here. We're going to go ahead, we're going to go ahead and thread across. Come back a little bit more. We're going to thread across extensor digitorum brevis, extensor hallucis brevis. And again, I would recommend if we're having issues with foot drop, let's consider the perineal nerve, the tibial nerve as well. See if we can increase that response from there. Okay, for perineal tendinitis, yeah, that's going to be that lateral pain, lateral and posterior to the lateral, posterior, and inferior to the lateral malleolus as peroneus longus and brevis comes and dives down in that area, whether it's a strain, whether there's an alteration in person's gait habit, those can be problematic in that area. So for our primary location is number one, it's going to be into the common peroneus longus and brevis tendon. It's kind of hard to break those two out because of their proximity, but we should be able to needle into that as a single needle to elicit a change there. Our secondary location, obviously, let's come up more proximally. Let's needle the peroneus longus and brevis themselves. And then lastly, we'll deal with the perineal tenosynovium. And so we'll talk a little bit later about, we'll hear in just a minute about tenosynovitis and our treatment approach there. You can take into one side here, one side and the other of the synovium and do some unidirectional rotation, and then basically just move that back and forth. Or because it's such a long structure, you can get into the tendon more proximally and into the synovium distally, and then isolate that and kind of mobilize that right there. So what that would look like on our 3D anatomy would be here. So number one, we would needle into the perineal, common perineal tendons, well, it's common path themselves. Secondary, let's come hit peroneus longus and brevis. And then lastly, let's deal with the synovium and see if we can mobilize that synovium away from the tendon and make that, that change there. We'll look at the lateral ankle sprain. Here, our primary location, the anterior talofibular ligament, the posterior talofibular ligament, and then the calcaneofibular ligament. And those are the three lateral collateral ligaments that support that lateral ankle. Secondary, we want to hit the inferior extensor retinaculum and the posterior tibiofibular ligament. And then tertiary, the superior fibular retinaculum and the inferior fibular retinaculum. Absolutely, lateral ankle sprain, not a substitute for completing good strengthening, good range of motion, good proprioception. But as far as dealing with that pain issue, that would be my three-tiered approach there. Bring up the library. And again, we want to catch the 3 ligaments associated with lateral ankle instability, as well as the superior fibular retinaculum, the inferior retinaculum, and then the other inferior retinaculum. So anything that comprises some sort of a stabilizing mechanism in that lateral ankle. For the Achilles tendonitis, let's come back here. We discussed dealing with the Achilles itself, but our primary location is we're going to be into the Achilles tendon itself. So we have the 2 away from this midline at the musculotendinous junction. And then we've got, so actually we've got the one in midline at the musculotendinous junction, and then down at the Achilles insertion onto the calcaneus as well. We also want to hit the gastroc and the soleus. And then for our secondary locations, the musculotendinous and the tendinous junction. And then lastly, the subcutaneous calcaneal bursa right there. So let's look at that here. Bring the library back. So we will be, move that out a little bit. So in the tendon itself, at the musculotendinous junction, there and there, we'll catch gastroc here, soleus, and then a little bit lateral of the musculotendinous junction there. And then lastly, the calcaneal, subcutaneous calcaneal bursa. So we deal with the muscle piece, we get involved with the tendon itself. Now, if there's a more significant strain, say some grade 1 strain of the tendon, that treatment location could be anywhere along the path of this tendon, from the musculotendinous junction all the way to the tendinous junction. So this is a proposal for a grade 1 tear. If there is grade 1, grade 2, it could be further along the path of that tendon. Achilles and malleolar bursitis, lump these 2 together. Our primary location here would be the subcutaneous calcaneal bursa, which we discussed. The secondary location, the Achilles tendon, the gastroc, the soleus, and lastly, the medial lateral malleolar bursa. Rarely will the malleolar bursa be involved, but if you do find issue with that, you could find that this would be fruitful for that. We will take a quick look at that since we're here. Very similar to what we would treat with regard to the Achilles tendonitis. We want to catch gastroc, soleus, the Achilles tendon, the subtendinous calcaneal bursa, and then lastly the bursa on the lateral and the medial malleolus. Okay, plantar fasciitis. Primary location for effectiveness of treatment and for compassion to your patient. Let's always start in the deep posterior muscles of the calf. Tib posterior, flexor digitorum longus, flexor hallucis longus, and peroneus longus. And I definitely target these because they all have an origin proximally, but they all have an insertion distally on the plantar surface of the foot. And most plantar fasciitis issues are related to either a change in foot mechanics or a change in our physiological function of an alteration in how we're walking. We start giving to something because we've got an issue elsewhere. And so we tend to see that pain manifest in the plantar surface of the foot, but very frequently it is these muscles that are involved in the problem. So much kinder, let's target those first. Secondary, absolutely, we want to hit plantar aponeurosis, the Adductor Hallucis, Flexor Digitorum, and Quadratus Plantae, all there. And then tertiary, if we can get to the tendon of Flexor Hallucis longus, which is that band that we feel coming all the way up to the great toe, and then laterally onto the abductor Digity Minimi. Come on. Almost there. Again, let's start on our posterior aspect first. Let's hit these proneus longus, tib posterior, flexor digitorum longus, flexor hallucis longus. Let's hit those, and then we can come to the plantar surface of our flexor digitorum brevis, our Quadratus Plantae deeper, Abductor Hallucis, and then Adductor Digity Minimi as a final resort. Also, if I can get that, the long tendon of Flexor Hallucis longus as well. Okay, so for tenosynovitis, again, I'm gonna deal with one. Let's go find extensor dig. Let's find our proneus longus and brevis, because that's going to be more common than some of the others. So for tenosynovitis, proneus longus and brevis, again, tenosynovitis being a constriction of the synovium, the tenosynovium, or the synovium around that tendon, making it difficult, similar to compression on a nerve and it not being able to glide. Similar here, synovium grabs onto that tendon and doesn't let it slide or glide like it's supposed to. We want to take in one, deal with the muscle that's involved, but two, we want to drop a needle in the proximal synovial sheath and then the distal synovial sheath, and then we're going to do some unidirectional rotation intent to grab hold of that. We're going to rock back and forth. We can stretch out simultaneously. We can push together, just elicit some mobility out of that tenosynovium, and then hopefully elicit that inflammatory response to get that tissue back how it needs to be. Lastly would be the proneus longus and brevis in that case. So let's take a look here. That is the wrong thing. Let's come here. Okay, so I don't have the tenosynovium here. So anyway, we described it adequately. All right, and then let's get past the tenosynovitis. There are a bunch of those, including the toes. I've indicated that you can do that for tenosynovitis of the toes. I will tell you, I've yet to have a case of clinical tenosynovitis of the toes. If you do have one, feel free to share it with me and love to hear more about it. If it ever shows up in my career, this is how we take care of it. Similar approach, distal, proximal, synovium, and do the tenting and mobilization. All right, so peripheral neuropathy. We'll touch on this. Have different approaches that we can take, but this is a nice approach to look at this for that distal lower extremity peripheral neuropathy. From a primary location, number one, we want to deal with things at the knee and below. That's going to be our common fibular nerve and our superficial and our deep fibular nerve. Secondary, we could look a little bit more at the higher at the tibial and the sural nerve. And then tertiary, if we wanted to come very proximally, we could look at the lateral femoral cutaneous nerve, the femoral nerve, the saphenous nerve, and the obturator nerve. Really and truly for our peripheral neuropathy, if we look mostly here at our primary location, common fibular, superficial, and deep fibular nerve, that is going to be the bulk of what we're going to see with our peripheral neuropathy problems. Our goal here is not to needle the nerves themselves, but get proximal or near to them, approximated to them, so that we can give some stimulation to those nerves, improve their conductility, improve the nerve, the blood supply in that area, and hopefully start to elicit that change. Been doing that for a while now and seeing really good results with peripheral neuropathy using this dry needling protocol. All those perineural protocols we've discussed previously, so I'm not going to go show you all of those. They're in the previous lectures, and so you can see them there. Haglund's deformity, it's also known as the pump bump or the retrocalcaneal bursitis. Painful enlargement of the back of the heel bone, becomes irritated by shoes. Normally appears as a red, painful, swollen area in the back of the heel. Women tend to develop this more than men. Changing shoes, soaking feet, any inflammatory meds are often can mitigate the symptoms. Obviously, consult your physician before taking meds, but I have treated it as well with dry needling. So in this drawing, we can see, for a lack of a better term, I like to consider this similar to the way we look at Osgood-Schlatter. We've got an inflammation of the attachment of where the tendon comes down, and we tend to develop a little bit of a bony spur back here, but we also tend to see significant bursitis behind the tendocalcaneal junction. And so our approach will be to try to needle posterior or anterior to that tendon, landing onto the calcaneus. So from a anterior to posterior direction. Primary locations here, from medial, on the medial side, we're going to go anterior to the calcaneal tendon with a backdrop onto the posterior calcaneal tuberosity. And then we're going to do the same thing from the lateral side. We're going to come from an anterior to posterior direction, landing right there. Our secondary locations, obviously, gastroc and soleus. And then tertiary, we could throw the Achilles tendonitis protocol at that. So let's come back and look at Haglund's here. Get my computer to work. There we go, if I can get there. So again, what we're going to try to do is needle from, come on down here. From anterior to the Achilles tendon to land, and not drastic, but just to land directly onto the calcaneus, anterior to that area right there. And we'll do it on the medial and the lateral aspect. Since we're at it, we want to hit the gastroc and the soleus. All right. Okay, so we've been through Haglund's deformity, concludes all of the foot and ankle, 7:58. That's 2 hours. All right, that's enough for one night. So our post-lecture assignment, there's a repetition that we've seen here. We want to go through all of our 3D kinetic screen. Again, I want you to find a mock patient, a real patient, submit a brief description of what your analysis of that 3D kinetic screen is, with focus on the trunk and the lower body, and then making a give your opinion of what muscle, tendon, nerve, what protocols do you think might be recommended to deal with their foot and ankle problem. Up next is lecture number 16, the 16th and final lecture of this series. Here it's going to be advanced dry needling of the pelvic floor. At present, that should be 2 weeks from now, which will be the last lecture in this series. And then after that, it is all about scheduling your time for your 3-day lab to get the certification in dry needling. So again, as always, if you have questions, if you have issues with the content, this will be recorded. I'll have it up on the portal starting hopefully tomorrow morning. We'll see how the internet's working tonight. Questions, problems, let me know. Otherwise, good luck with the content, and we will see you for the final lecture here in about 2 weeks.